Kia ora, I'm Dr. Helen Joyce and I'm a general practitioner. I work at the Goodfellow unit with the University of Auckland. Today we're talking about gout in Aotearoa, New Zealand. The specialists I have with me today are Professor Nicola Dalbeth, a rheumatologist and academic doing gout research. Also Leanne Te Karu, a clinical prescribing pharmacist and founder of the Māori Pharmacists Association. Welcome, Nicola and Leanne.
Kia ora, Helen.
Now, gout is one of the most common forms of inflammatory arthritis, and it has it's related to a whole lot of really negative health outcomes and a poor life expectancy. However, it is a controllable condition. Can you give us a short overview to start of the ideal treatment or management of gout?
Sure. So, as you say, gout is a chronic disease, and it's a chronic disease of urate crystal deposition. And so really, if we're thinking about treatment options for patients with gout, for patients really the really important thing is effectively managing flares. And so that essentially means patients having available, safe and effective anti-inflammatory medication. So having an action plan so when they experience a flare, they can rapidly treat that and safely treat that. Of course, gout is not just the flares, and those patients who have persistently elevated serum urate concentrations, even once the flare has resolved, will have chronic urate crystal deposition. So in the long term, effective therapy of gout requires long-term urate lowering therapy to reduce the serum urate concentration, dissolve the crystals, which in turn prevents flares and also leads to resolution of tophi if they're present. And essentially the way that we achieve this is with urate lowering therapy, which is a long-term therapy, and for most patients that treatment would be allopurinol.
Possibly just to add to that, Helen, is once we do have an established diagnosis of gout, that's your time to then do what I call cultural literacy and apply those 101 health literacy measures with people in a culturally safe way. You know, really sort of engaging and asking people what they know about gout, and therefore that's your premise to move forward on, to unpick those myths. You know, certainly prevent those myths from being perpetuated and really engage around this long-term therapy, because you know it is an enigma that we have a condition that is associated with increased mortality and this absolute suffering, yet you know we don't always do so well in this space.
So how is gout affecting the health of New Zealanders then?
So we know that Aotearoa has the highest rates of gout worldwide. So if we look at the overall adult population, about 5% of adults in Aotearoa have gout. And there are particular groups in New Zealand with very high rates of disease. The highest rates are seen in Māori, and we know that about 10% of Māori adult men have gout. And also in Pacific people living in New Zealand, and so in Pacific people we're looking at the order, at a rate of about between 12 and 15%. And of course, gout is more common in older people as well. And so if we're looking at older people, older men over the age of 65. Almost a half of Pacific men are estimated to have gout, of those living in New Zealand, and about a third of Māori men. So I think this is a really important statistic. It's actually a sort of key area of equity in New Zealand.
It's a huge problem.
It really is. Yeah. You know, I think the other really important statistic is around the age of onset as well. So we know that on average, Māori and also Pacific people living in New Zealand experience gout, when gout develops, about 10 years younger than Pākehā New Zealanders. So this is a condition that affects men of working age, and of course then has impacts on work disability, on finances, on ability to participate fully in whānau, in community, all of those issues. So this is a really important health problem.
Oh, it's a significant problem, Helen. I think that, and a point to remember is we did some very robust research, but we aren't always able to catch the people that don't seek help or don't front at a GP clinic, borrow medicines, that might buy over-the-counter non-steroidals. So, what we've captured in terms of data is significant, but it may not be the bottom line,
And what are some of the negative health outcomes that these people are going to possibly be expecting then?
Well as the impact on work, finances, all of those other things I've already talked about, gout it's an extremely painful condition. People with gout are exposed to toxic therapies like NSAIDs, colchicine, corticosteroids, which can lead to a whole lot of other health issues. Gout often is a reason that people give up exercising or find it difficult to exercise, and then there are all these downstream effects on risk of obesity, risk of diabetes, risk of cardiovascular disease. The gout itself is also really important in its own right.
Yeah.
So poorly controlled gout can lead to chronic joint inflammation, joint damage, joint deformity, all of these really negative outcomes. And again, these are complications of the disease that we see more often in Māori and in Pacific people.
So the ramifications are quite wide-ranging.
That's right.
The ripples go far.
That's right. How well is gout managed at the moment in New Zealand?
So again, we know that if we look at allopurinol prescribing, so allopurinol is by far the most widely used urate-lowering drug. It's first-line urate-lowering therapy for people with gout. And approximately 40% of people that we think have gout, and this is again probably an underestimate, are receiving regular allopurinol.
Right.
So of course there may be some people who get very infrequent gout flares, who perhaps have made a decision that they don't want to take long-term therapy, and of course there are people like that, or people in that situation who've made that choice for themselves. But I think that there's also a substantial number of patients who are not receiving that care, or if they're receiving allopurinol, are not receiving sufficient dose to really effectively treat their therapy, to treat their gout. So I think that it's a real challenge. I think it's a huge challenge for patients and for prescribers when we have a flaring condition where people feel well in between attacks. I think it takes quite a lot of time to sort of dig down and really help people understand that actually even when they're not experiencing a flare, that it's important to be taking their allopurinol regularly. And I think it's really important for prescribers to see this as a priority and to be ensuring that there's regular supply of allopurinol, that it's dosed adequately, that the serum urate's measured from time to time to actually ensure that the dose is right. Because gout it's incredibly treatable and preventable. And we have a really effective, safe therapy in the form of allopurinol, and it's a real shame that more people aren't getting access to it.
So sadly, we could be doing a lot better, Helen, and the evidence is telling us that we haven't made a shift in the years that we've certainly been measuring together and having a look at the data, that we aren't responding well as a country and dealing with something that is preventable and shouldn't be occurring and carrying significant sequelae.
Yeah, you mentioned the health literacy, which obviously is a significant part of this. Can you expand on that a little bit more?
Sure, yeah. I prefer to think more around the ability of health professionals to deliver understandable information as opposed to stating that a person has low health literacy or etc. I take umbrage at that. In fact, it is the onus sits with us as health professionals to deliver understandable information. And repeatedly, I meet people who say, "Why was I never told this? Why do I not know about this? How did I know that this is a treatable condition? How did I not know?" All of those types of things. That the myths. How have they been perpetuated throughout time? Why is it that when people are fronting at primary care practices, the first question they're asked is, well, what have you been eating, or what have you been drinking? You know, this sort of thing, which does stigmatise, and people feel judged, and those ripples continue to widen.
So it's us in primary care that maybe need to be increasing our ability to, access and talk to our patients better.
Oh, absolutely. You know, we can be doing a lot better in this space. I guess I've had the greatest traction with people when I've worked substantively in the community with people, so that they're on absolutely the same page too. But equally, it falls over if those people then approach a health interaction or a consultation and those messages aren't repeated, or they're made to feel that they're judged, and then that we don't have the right prescribing associated with that. So yeah, you need everybody to be working in unison, I believe, collectively.
Are there any other gaps in care that you guys see in the community or in your work as a rheumatologist?
I think perhaps naively, maybe a couple of decades ago, Helen, I thought, this is such a simple problem, so how can we not, it's an enigma to me, we have the ability to diagnose gout with 100% certainty. We have a medicine that we have extensive history on, it's relatively safe in terms of medicines. How is it that we have not made, we're continuing, Nicola and I and others, to find, the same response? How is this not happening? So, I do think it is multi-layered, it's a multi-approach. I've implemented a number of things in a South Auckland practice where I work, and some of that's involved a decision support tool at the point of prescribing, so that we are prescribing the correct dose of allopurinol at the time, and that cover is considered. I think that's an area, Nicola, that we, as prescribers, we might overlook at times as cover, and, I think 95% of the time I would advocate that we should be giving cover. But it does have to be this multi-layered approach, because as Nicola indicated, it can be a bit of time up front. My response to that would be you mitigate people having to return multiple times for these fairly toxic medicines to manage things that are preventable. So there is trade-off in that.
I think we also know that there are certain certain groups in Aotearoa who get, who don't get such good care. And I think if we look at who's really most affected by gout on a population level, actually Māori and also Pacific people have earlier onset disease, more severe disease, more frequent flares, more hospitalisations. And yet, if we look at allopurinol prescribing, it's those groups who actually are getting less allopurinol. So again, I think that we really need to look at our own practice, all of us as practitioners, and really think about ways that we can improve care for those who are most affected by the condition. And I think it does take time, and I think that consistent messaging is so important. So often I've heard patients say, again, I never knew about this. And maybe they have heard about it, maybe they've had such a severe pain in their foot that actually nothing goes in at that point. Or I went and saw someone and they told me that actually I just needed to stop eating seafood all the time. Or I needed to lose weight. And actually those are really not useful messages. We have very little data to support the concept that actually dietary management for patients with established disease actually alters the outcome of the disease. And I think we spend a lot of time, probably wasted time, really focusing on that, where actually the time could be much better spent, explaining in a way that's understandable the underlying basis of the disease, which is crystal deposition, and how we need to dissolve those crystals by getting the serum urate down.
So it seems like we as a medical community aren't engaging with our patients in the way that is effective, or that we should be.
Yeah, I think there are some real systems issues as well, actually. I think that actually, just the way that our healthcare is set up, particularly for people who are working, is really difficult. I think when people are feeling well, and they're on regular medications, it's really difficult to think, well, I'm going to, I've had all this time off work, I'm now back at work, and now I'm going to take some more time off work to go and pick up my prescription. So I think if we can really look at systems within all of our practices where actually we can make it easier for the patient, I think that, easy to do the right thing, I think is just so important. And I think that particularly with things like allopurinol prescribing, there's a real opportunity there with alerts and reminders and trying to do more remotely as well. And of course we can really easily monitor what's going on with a very simple test, which is a serum urate test. So, I think that looking at innovative ways of practicing and working with patients is really important in the gout space.
And in the equity lens, how does it work that we have a condition that predominantly affects people with the poorest health outcomes, and yet they are the people that are receiving the medicine to treat it less often?
And also getting more non-steroidals.
Yeah. We have lots of evidence around that, and that's not the people that are buying or sharing, it's the data that we collect, through prescriptions. So
why do you think people prefer taking non-steroidals rather than daily urate lowering therapy, despite there being a risk of long-term problems?
I think people don't necessarily prefer, Helen, that they haven't had that all laid out in an understandable manner for them, and they're certainly not aware of possible side effects. I think when you do manage to sit down and really spend that time and pull back the understanding that people have had previously and address that and work with them, and then check that for their understanding back in that process, that they don't prefer having the medicine that's going to treat the symptoms and not the cause. I think that's a fundamental issue to start with.
And again, I think we need to look at prescriber beliefs as well, because I think that traditionally there's been a lot of fear around allopurinol, particularly the fear of a very rare but important side effect around hypersensitivity. And I think that prescribers have been anxious about dose escalating allopurinol and actually using effective doses. And I think what I would say is actually, certainly in the last 5 to 10 years, we have really good data to show that actually allopurinol is probably the safest urate lowering drug that we have, that if we start at a low dose and gradually titrate the dose, the risk of flares and probably also the risk of hypersensitivity is actually even lower. And also that actually there are probably quite substantial benefits for cardiovascular risk and also for kidney function as well. So actually overall being on allopurinol is good, not just for the joints, but probably also for cardiovascular and renal protection as well.
And there might be a key tip in there, Nicola, in terms of you're in your practice and creatinine's kind of shot up or something. It's not necessarily the time to stop allopurinol.
No, absolutely.
Please don't.
Carry on. If you're tolerating it, keep taking it, no matter what.
That's probably a change in thinking for the medical community as well.
That's right.
Getting that on board. Yeah. What about access to medicine? So you touched on before the allopurinol being harder. And anti-inflammatories being something you can buy from the supermarket.
Sure, yeah. And I think that's, again, I think it's that issue about talking about the disease in its entirety. So actually, this is the long-term strategy, which is the urate lowering therapy, the allopurinol, and for that first few months, actually there is a risk of flare, and so we're going to cover with some anti-inflammatory prophylaxis. We're going to start at a low dose and gradually titrate it up until the urate's at target, and then this is what's going to happen if you get an attack. And I think that's a really, I don't know what you find, but I think this is actually a really important part of the whole package, is actually acknowledging the importance of the flare for patients and making sure that they've got a strategy to deal with that and an action plan. And I think my sense is actually that's really important for that kind of collective moving forward is to really recognise that.
It's absolutely key, I believe, Nicola, that you have to spend time, alerting to people that this is a possibility. The first 3 months can be a little bit rocky. We're going to implement some cover to try and mitigate that happening, but actually, be aware of that we will get through this, kind of 3 months, and, the long term plan is to have you at a level where you can eat what you want, where this isn't happening, where your work isn't suffering, where your family isn't suffering, where these ripples, as I mentioned, go far and wide. So people do, they do respond to that and understand it.
You've touched on a few things that we can do differently, as you say, those practice points, which are really great to take home. What else could we be doing in primary care just to make our management more effective?
I think that there's a lot of data now to show that nurses and also pharmacists have a really big role to play in gout management. And I think not just focusing on the doctor and the GP as the gout provider is actually essential for good care. There's been a very big study from Nottingham that's recently being presented demonstrating that a nurse-led gout program leads to substantially better outcomes, not just serum urate lowering, but also improvement in flare, tophus, health-related quality of life, and actually having protocolized allopurinol dose escalation, that contact, that regular contact, actually ensuring that things are progressing in the way they should, I think is really important and is a huge opportunity for primary care. And I think actually those kind of models, pharmacist-led models, nurse-led models, actually are really the way to go for effective gout management within the community.
I mentioned the multi-layered approach, and that's precisely what I was alluding to, Helen, that when you're all members of the team are of the same understanding, you're working together, and we've even got our receptionists who understand, know the messages with action plans and that sort of thing. So yeah, very much multi-layered, and our kaimahi that are out in the community, again, working with whānau to understand those really important messages. So it has to be a multi-pronged approach. In my experience, it doesn't work when it just sits in one place. We all have to be in this space together and ensuring that whānau are getting the right messages.
Thank you. They're fantastic answers. What are your take-home messages that people watching this can go and use in their practice now?
I think my key message is really, look at your practice, look at what you're doing. Actually look at how many of your patients have had a serum urate measured in the last year. Of those, how many are actually at target? And if they're not at target, actually what's happening with their gout? If they haven't been measured, what's happening with their gout? If they're on small doses of allopurinol, are they on enough? Really kind of thinking about those and really thinking about the condition from a long-term perspective, not just we need to just deal with the flare and move on to the next person. I think that's really the key. And there are very good audit tools within primary care that actually make this really possible.
So possibly only adding to that, Nicola seems to have covered a lot there, but the next time you get a gout patient, say to them, well, what has somebody sat down with you and told you, what do you know, tell me what you know, and spend that time engaging and trying to make sure that they do have the correct messages and fully understand that it is a preventable condition and they need not suffer from it. And people do have this kind of sense of futility that, it's going to happen anyway, I need to expect that it's going to happen, and really make sure that they know that it doesn't need to happen. Prescribe allopurinol appropriately according to creatinine clearance, and ensure that you've got cover in there, but stop your cover as well. Don't leave that in long term. So yeah, probably just some key messages.
Yeah, thank you, Leanne and Nicola, for your expertise on such an important health topic in New Zealand. Hopefully we can see some changes come into effect in our communities. Thank you.
Great.
Thank you, Helen.